I'd like to welcome you all to our second AVE webinar with our medical professionals, our doctors. Before we begin, I think it's appropriate to start with a prayer. So if everybody can hear me, I'll just say a couple of words in the name of the Father, and the Son, and the Holy Spirit. Amen. And I just like to thank God for bringing us all here together. I like to pray for the community. I'd like to pray for the doctors that are here today, and thank them. And I'd like to pray for a solution to this, and for all of you that are here and all of your families and everybody that's been affected by this. So pray a quick Hail Mary. Hail Mary, full of grace, the Lord is with thee. Blessed art thou amongst women, and blessed is the fruit of thy womb, Jesus. Holy Mary, Mother of God, pray for us sinners, now and at the hour of death. Amen. Thank you.
Amen.
All right, so as I was saying, I'd like to welcome you to our second AVE. We had one a few weeks ago, and it was a big success. And a couple of housekeeping tools that we want to go over. And I have Pep Lopez Varela from Class of '87 helping me out. He's my wingman today, and he's making sure that you're all on mute. And just want to make sure you stay on mute. So today we're talking to the doctors. We have an amazing panel of four doctors, 3 alums, 1 alumni parent. I'm going to introduce them to you in a few minutes. And we hope that we get some questions answered for you. You know, any myth that's out there, anything that you want answered regarding the opening of you know, just the country, the city. You know, what's it going to take? You know, these guys are in the front line. They're in hospitals, they're in practices, and they have a lot of good information. I was very lucky to speak to them yesterday, and so on. So we're going to go ahead and get started then. So first doctor I want to introduce you is Dr. Bert Moreno, class of '96, cardiologist. So Bert, go ahead and say a few things about yourself. Unmute yourself, Bert.
Oh, there you go. Thank you. Hi, I'm Bert Moreno. I'm a member of the class of 1996. It's a pleasure to be here. Thank you, Carlos, for inviting me. I'm a cardiologist in Miami-Dade County. In addition, I manage a cardiovascular practice that practices in Dade and Broward. Additionally, I've been part of the team that has staffed all the COVID field hospitals in Dade County over the course of the last 2 weeks, and I'm looking forward to answering any questions and being a resource to the group.
All right. Thank you, Bert. Next doctor is Dr. Eduardo Martinez DeBouchet, class of 1990. He's a Baptist and critical care unit and other stuff, among other things. So, Eddie, go ahead, take it over.
All right. Yeah, I'm currently a Baptist, class of 90, as you said, our 30-year reunion this year. I've been practicing critical care at Baptist Hospital for about 12 years. I was faculty at the University of Miami before that. Graduated medical school in '97. I'm here to serve and answer your questions today.
Thank you, Dr. Martinez DeBouchet. Number 3, Dr. Mike Hernandez, class of '94, pulmonologist. Take it away, Mike.
Yeah, my name is Mike Hernandez. I do pulmonary critical care. I'm affiliated with Baptist Hospital in South Miami. Went to Dallas briefly for training for 6 years, and then I've been back since probably like 12 years ago. It's been a while. So I'm happy to be here, happy to be invited. Thanks.
All right. Thank you, Mike. And finally, we have an alumni parent, Dr. Juan Perez Morales. So go ahead, Doc. Take it over there.
Hi, thank you for inviting me. I'm just an infectious disease doctor. I have been in private practice since 1991. I practiced for many years at Baptist, and now I'm at Jackson South Hospital for the last 3 years.
All right, perfect. So thank you, boys, and thank you for doing this. So let's start real quick with a question to everybody, and just to give people an idea about the COVID virus itself, COVID-19. Let's talk about the myths associated with that. I'm opening up to the panel here for you guys to chime in, and anything that you want to say about it right now, latest, anything that you can, let people know about the virus itself, about, the way the treatments are going, anything you can chime in on that. So let's start with Bert. Let's start with you, Dr. Moreno.
Hi. Yeah. So COVID-19 is a very serious viral illness that primarily affects the respiratory system. I'll speak to the cardiovascular system and the effects of COVID on it. But everything that they're saying in the media and everything that they've been noting and the resources that we're all looking at daily are sufficient and have been letting us know that we should be scared of a virus that can affect young people and old people. However, it does affect people with pre-existing conditions more than others. And so that pertains to cardiovascular disease as well as other pre-existing conditions in any other organ systems. You know, COVID-19 affects the cardiovascular system in multiple ways. It can lead to myocardial infarction because it's a virus, so it increases inflammatory markers. It can cause direct injury to the heart muscle. It can lead to arrhythmias, and it also causes clots in the small arteries and in the bigger arteries of the body. Additionally, some of the treatments that we've been using for COVID-19 have secondary effects that can affect the heart and can cause complications. And so when we're thinking about the therapies for COVID-19 from a cardiovascular perspective, we also have to be thinking of the side effects that those therapies cause. And then the other thing, which sometimes we don't think about as much when we're thinking about COVID-19, is that COVID-19 has put such a strain on the hospital systems that what we're finding in cardiology is that people who have other cardiovascular diseases aren't having access to the ER and aren't coming in for common cardiovascular complaints. And our suspicion is that it's going to lead to an increased incidence of cardiovascular mortality and morbidity. And so those are some of the things that we've been thinking about from the cardiology point of view as it relates to COVID. And I'm sure we'll get into those things more throughout the course of the talk.
All right. Eddie, Dr. Martinez?
Yeah, I think one of the myths out there is that this disease may just be like a typical flu. And I want to be very clear that this is not flu. This is a significant, formidable virus that has caused a lot of harm in communities that haven't taken the precautions necessary to socially isolate and diminish the viral transmission of this disease process. So I hear that a lot on the street. Oh, this is just like flu. The mortality isn't that high. That is a myth. You know, the mortality is high. For all of us here on this panel, we really haven't seen something similar to this in terms of how acute the patient can potentially present to a hospital and overwhelm a facility in terms of all the resources available to take care of them. One of the things that was just published yesterday in JAMA, Journal of American Medical Association, was the mortality numbers for New York for this disease. And something astonishing to me was that in New York, 88% of patients who ended up needing a ventilator died on the data that they showed yesterday. And that is currently not what is happening here in Miami. We have a mortality on the ventilator much lower than that. I can't give you the exact number, but I'm putting it somewhere in the 20 and 30% range. And the explanation that I have for that is that New York was overwhelmed with the amount of patients that presented with that disease. So what we're doing right now in terms of socially isolating is extremely important. And one of the beautiful things that has occurred with this disease is that the social isolation has actually worked and diminished the case presentations to our hospitals. And that's phenomenal, because had it been something like measles, it would have been very hard to socially isolate and protect ourselves from something that communicable. So it has responded in terms of the prevalence on the street of that virus did respond to our social isolation measures. So I think I'll start with that, and we could talk a little bit more about it amongst the panel.
All right, thank you. Dr. Hernandez?
Yeah, I'm just going to echo what Dr. Martinez said. I have a lot of friends in the community, non-medical, and they keep asking, hey, is this serious? Is this serious? Is this just hyped up by the media? Is it just paranoia, hysteria? And the fact of the matter, it's the biggest pandemic of our lifetime. We were lucky in that, unlike Italy, we had an advanced warning. We saw what was happening in Italy, where the mortality was 11%, 12%, something crazy. And we were able to, as a hospital system, we were able to eliminate certain things that would take up beds, like elective surgeries. We were able to socially isolate, and as a result of that, if you look at the mortality in Florida, it's incredible compared to Italy. New York was was overwhelmed at first, but they did do well at the end of the day, and no one that needed a ventilator didn't get a ventilator. People were running out of ventilators in Italy. They were withdrawing care on people just because they lacked resources. So it is extremely serious. Having said that, a majority of our patients are recovering. We do have the resources to take care of them. Like Dr. Martinez was saying, the patients in Baptist are doing very well. And we've learned a lot. We've learned a lot from a medical standpoint of what China did, of what Italy did, of what our doctors in New York did. And I got to say that the doctors in New York, the critical care doctors in New York were incredible. The way they accommodated everything. I mean, they got thrown into this, and if you look at their mortality data, it's high, especially for patients that were intubated. But overall, if you compare it to other countries, it was significantly better than the other places that were hit, including Italy and China. So, you know, it's been wild. I mean, these patients are coming in and they're sitting there in a hospital bed on no oxygen, spiking fevers every day, looking okay. And then day 6, day 7, when you would normally just discharge these patients, you know, they're crashing. And so it's something that we haven't seen, that I haven't been used to seeing. But we quickly adjusted. I don't know, Dr. Perez, you can kind of speak to this. This hasn't behaved like a normal flu.
No, absolutely not.
All right, so go. You're on now, Dr. Perez. If you can just chime in on what we've been talking about.
Yeah, in order to give everybody a perspective, and I think that was an excellent overview of what this virus is capable of doing. Since COVID became an outbreak in December, perhaps even earlier in September or November, we have at least over 1,500 publications, most of which come from China, and at least 30 to 35 publications almost on a daily basis. The reason why I'm mentioning this is because we remain in the dark as far as things to know about this virus. And at the same time, what we know today is completely different about what we knew 3 weeks ago. And I'm sure it will be different what we'll know 2 months from now. Having said that, some generalities about the virus, as Dr. Martinez and Dr. Hernandez said, this is definitely not influenza. It has a lot of similarities, but also has a significant number of disparities. And most importantly, than the fact that they have similar symptoms, they're both viral illnesses, although caused by different viruses. They have a spectrum of disease that goes from mild to severe. They can both cause pneumonia. The main difference is that influenza is readily preventable. We have a vaccine for influenza that will eventually become a mandate now with coronavirus in the horizon. Number 2, we have treatment for influenza, and we have prophylaxis for influenza. Now, the main difference, if I was going to choose one, is that, including myself, at the beginning, I thought this was just another flu virus. Boy, was I wrong. Influenza causes, just in the United States, 9 to 45 million cases a year, but only up to 61,000 deaths. Worldwide, influenza causes an estimate of 1 billion cases every year. COVID so far in the US, in 2 or 3 months, has caused, talking about round numbers, about 850,000 cases with 47,000 deaths. That just goes to show you the main difference in mortality, infectivity, contagiousness. But most worrisome is the fact that we don't have any FDA-approved treatments for COVID at this point. We're all using different treatments, mostly adjunctive treatments, based on what our different institutions have or whatever clinical trials they were able to enroll in. But treatment modalities are not homogeneous across the board. I just wanted to throw that out there because I'm sure we'll be talking more about it during the course of the session.
Yeah, and that was the thing that kind of caught everybody off guard, because even though we knew it was coming, we had no treatment for it.
Right.
And in our facility, we're giving hydroxychloroquine. We are giving azithromycin. The first case that we saw at this hospital that we diagnosed, we were able to get remdesivir, which was made by Gilead, which you hear about a little bit, for compassionate use. And we were able to get it on that patient. Since that time, we haven't been able to get remdesivir. But we are giving patients hydroxychloroquine and azithromycin. I cannot tell you if it's working or if it's not working. I don't know if it's working. We're giving it because that's essentially, it's not going to hurt for the most part if you monitor them from a cardiac standpoint, because some of the hydroxychloroquine and the azithromycin can cause some cardiac irregularities that Dr. Moreno can speak to. But we are monitoring those patients and we're giving the drugs. But I can't tell you if it works or not.
Yeah. So if you're speaking about therapy, if you guys look at the IDSA, the Infectious Disease Society of America, put out a statement that basically all therapies should only be done under a trial. And the reason for that is exactly what Michael Hernandez is saying, is that we don't have any evidence. We're trying things that physiologically should work against this pathogen. We know why maybe azithromycin could work, but actually the literature doesn't look like it's useful at all. And then the same thing with the hydroxychloroquine. And as you mentioned, there are some risks to putting some people on these medications. We have to monitor them for arrhythmias. The other component, which is that we're addressing heavily, is trying to modulate the host's immune response to the infection. But it's funny because for the last 40 or 50 years with sepsis, we've been trying to work that angle for many years and not been able to come up with anything that has actually worked for modulating the host immune response. So basically, the inappropriate response, that we're having, that's causing all the inflammation and leading to the death on these patients. But of course, as Dr. Hernandez said, at this point, we're really grasping at straws, but we should be doing them all under the guise of research to make sure that we're investigating appropriately and deciding, afterwards whether what we're doing is right or wrong, or deciding to stop it if it's actually hurting patients. It is really difficult. This disease actually very much targets specific individuals who have different genetic immune responses. And this is the part that we really don't know much about. So we don't understand the differences amongst our patients and their phenotypes, how they present, and the fact that we're all genetically different and all code differently for all our multitude of immune response modulators that we have. So this disease preys on some very healthy people that have a very inappropriate immune response. And so it's not only a disease of people who have comorbidities like diabetes or hypertension, but we have, some of us have really good friends that are very ill right now, on machines that were healthier than I, and could outrun me on doing 6-minute miles on their split. So those people obviously have different genetics, and there's a lot that we don't understand as to why those people are more susceptible than others. But what we can tell you, and I think Bert can speak to this, is keeping yourself healthy is probably the most important thing that you could do with this. So knowing that we don't have very distinct therapies that are absolutely working, what we can tell you is that control of your diabetes, control of your blood pressure, avoiding overeating, avoiding alcohol makes huge differences in terms of what your outcomes will be with this virus. Bert, I don't know if you could talk to that a little bit. You're muted there.
Bert, you're muted.
Yeah, so and it's interesting that you say that, Eddie, because Carlos had mentioned some of the myths or misconceptions associated with the virus. One of the things that was floating around was because of the virus's affinity for the ACE2 receptors, whether or not patients with hypertension should be taking their ACE inhibitors or their ARBs. And all the cardiovascular societies kind of unilaterally came out and kind of said, absolutely, the effect of hypertension and poorly controlled hypertension is very deleterious to to the body and causes increased risk incidence of stroke and heart attacks. And that risk weighed against an uncertain effect of ARBs or ACE inhibitors on the virus. You want to keep taking your blood pressure medications. You want to stop smoking. You want to stop using the vapes. You want to keep yourself in good shape and exercise. And all those things will prepare you. But obviously, like Eddie said, one thing we're finding is that it's very difficult to predict who's going to do poorly and who's going to do well when confronted with the virus. The other thing I'd like to hear is, because of the diffuse inflammatory cascade, which is causing most of the damage in the body, we've been using pretty much on all our patients anticoagulation to avoid the microvascular complications in the brain, in the kidneys, in the lungs. And I was wondering if maybe one of the pulmonary doctors might want to explain how these small thrombi or these small microemboli are the reason why, some of our friends and people we know and people all across the world are having a difficult time getting oxygen into their arteries.
Well, the answer is we don't know, okay? Just like a lot of things in this COVID thing. For instance, I'll say this. When we first were reading about COVID, Bert, they were saying, listen, if the patient's oxygen requirements are escalating, for instance, if they come in 95% room air, 98% room air, just monitor them. The minute their oxygen requirements start escalating, you should intubate them, put them on a ventilator early. Now we know, many weeks later, that's the wrong thing to do. Because when you put them on the ventilator, you totally screw up their hemodynamics, you screw up all their perfusion, and all their autoregulation within the body that's protecting the body and kind of fighting. You've kind of distorted that with the ventilator, and that's why they were seeing that patients on the ventilator, 85% of patients were dying. Okay, there is a subset of patients with coronavirus 19 that come in that look like they're having microemboli, and the tip off there is that their D-dimer comes, which is a marker for the non-medical people. It's a marker of blood splitting blood products. When it's elevated like that, the theory is that you should put those patients on blood thinners, and we are putting some of those patients on blood thinners with diffuse inflammation and elevated what we call D-dimers. Okay, is there a mortality benefit? We don't know, and that's what's tough about treating this, is that we don't know a lot of what we should be doing, when we should be doing it, how early we should be doing it. We're kind of just rolling with the punches, and a lot of us are in the dark trying to do the right thing. But I will say that in our facility, we are anticoagulating many of these patients, and we are ruling out blood clots on a lot of these patients. We're not finding some of these blood clots, but we still anticoagulate.
I think it's difficult sometimes to study some of these patients and figure out if they even have blood clots. They're so unstable. They're on ventilators. They're so labile that they just moving them around, their oxygen status goes down, and it's been unsafe to take them to CAT scan. And so what we've been doing, like Michael Hernandez said, is we've if they have potential, which this virus does increase your likelihood to thrombose, if they have a potential for that and they're doing very poorly and their inflammatory markers are very elevated, including that D-dimer, then at that point we consider not only prophylaxing against developing clots, but actually treating with blood thinners. But the data, definitely not there. I think when it comes to this disease, there's going to be a lot more information based on the studies that we're looking at. None of them now are typical for you scientific folk out there. They're not really randomized controlled trials. A lot of these are going to be prospective observational trials, which means that we're going to be doing different things and then later trying to figure out if there was a lean towards improvement in outcomes in these patients. But right now, as Dr. Hernandez and Dr. Moreno were saying, we're basically rolling with the punches, and we're adjusting on the fly. And we've learned a lot of the things that were being done in China and then early on in Italy were probably deleterious, and that's fine. And it may be that some of the things that we're studying right now are deleterious too. I think the other thing that we could talk about out there is this convalescent plasma. And Juan, maybe you want to touch base a little bit on convalescent plasma. I know everybody out there in the community knows that the mayor donated after his stint with the virus. He donated some of his plasma. So Juan, I don't know if you want to touch base on that.
Right. Convalescent plasma has emerged as a potential life savior at the present time, although it's not readily available in every institution. At Jackson, for instance, it had to go through IRB approval, and we tried to do it as a whole, as a system, and we had to do it individually per hospital. So it's still going through the paperwork. But convalescent plasma in small groups of patients, again, Chinese literature suggests that it's effective in improvement of the usual parameters that we've looked at, like oxygenation, extubation, recovery, and eventually discharge from the hospital. It's not that simple because it requires that we screen from, for donors, people that have either recovered, or ideally that by now we would have an effective antibody system that would allow us to detect people that may have been infected and were completely asymptomatic throughout. So I think finding donors at the present time has become a reality that we don't have enough convalescent plasma for everybody, which has brought up, the need to create protocols that sometimes are not very realistic, patient-oriented wise.
Yeah, I think one of the things that's interesting about that is that our patients, a lot of them late into their disease process, still have their virus positive on their testing. And that's what makes this disease a little special. I was initially a little bit hesitant on the convalescent plasma being given so late, like Dr. Perez Morales is mentioning, because that's not usually where it's beneficial. I mean, we're trying to confer some immunity. Think about like mother's breast milk, sending out antibodies for the babies. The same idea is that these people that have antibodies out there, that we can confer some of that immunity by handing them those antibodies to the other patients. But we really, we generally do that early on in the disease because, as Dr. Perez Morales says, usually by the late stage, a person has had an antibody response. But what it appears here is that not every immune system is the same. Some people clear this virus really quickly and some don't. And there is a lot of late stage viral positivity in this disease process that suggests that there might be some benefit in conferring some immunity with that. So it's been interesting, and again, it should be done, as you mentioned, in a research trial. It has shown a lot of promise in other diseases. Definitely in Ebola, it was a lifesaver for that disease, for that viral process. So right now, like you mentioned, we're only using it in very late stage patients that have advanced respiratory disease and are progressing and doing poorly. But not ideal, I think, like you mentioned, because there's just not enough availability, and that's why it's left to that group of individuals, and may be better earlier in the disease process if we had more.
Eddie,
so
go ahead, Bert, go ahead.
Yeah, there are other medicines that we've been using in the inpatient side, like.
We lost you, Bert.
Yeah, hear me.
There you go. You got it. Go.
Yeah. So we've been using other medications in the hospitals, like corticosteroids to modulate the immune system. But just to bring it back, because the vast majority of people probably on this meeting are not in a hospital on the front lines. One thing I was thinking might be beneficial to talk about are the initial presenting symptoms, and if you were to get those, I'm sure Dr. Perez Morales has received countless calls from his patients or his family members. Hey, I have this, I have cough, I have my sore throat, I have fever, and what might be to get evaluated by a physician, and where you could get tested, and where you can go forward with assuaging some of your concerns if you have them.
Yeah, I mean, the presentation is very similar most of the time to influenza. We're talking about fever, we're talking about cough, we're talking about shortness of breath, we're talking about sore throat, but it may also be very atypical in the sense that even though GI symptoms are reportedly less common, I have seen a handful of patients present exclusively with GI symptoms, namely loss of appetite, nausea, vomiting, diarrhea, and even abdominal pain. without any respiratory symptoms whatsoever. So presentation can be highly variable. Neurologic confusion, fogginess, particularly in the elderly, and sometimes, very non-specific symptoms. Now, what to do in the event you experience some of those symptoms? Number one, I think you need to call your primary physician, even though I'm aware that most practices are closed, but I like to believe most physicians are available by phone, and most are also doing telemedicine consults. So that would be the first, advice, to call your primary physician. If you have been exposed to any confirmed cases of COVID, or you consider to be a high risk factor, like recent travel to highly endemic or hot areas for COVID infection, you can have yourself tested. And I think, most hospitals have designed tents outside their emergency room for rapid testing, and there's also a lot of drive-through testing stations that you can go and get tested. If in doubt, and your symptoms are basically mild, meaning, headaches, some cough, body aches, etc., you can potentially self-quarantine yourself, assuming that you will not get clinically worse. In which case, then you still need to get tested, and probably when you experience shortness of breath or a prolonged febrile episode, you probably end up going to the emergency room.
Hey, Juan, I want to tell everybody that we got that Baptist Care on Demand app. It's actually free. So there's a section there to go into flu and COVID. It's so if you get the Baptist Care on Demand app, you'll be able to see the sections. The flu and COVID section is free. You can check in there, and you'll speak with nurse practitioners. I have a few nurse practitioners on the app currently working. We have from our ESU, we have like 7 or 8 of them that are registered. They'll take your call, they'll evaluate you, and if you need to get tested, they'll refer you to the testing sites. What we don't want you to do is necessarily feeling sick walk into our office directly. So there's ways for us to have you call ahead. We can bring you into a side entrance, into a special room, or give you a mask and protect the people around in the practice. So there's different ways that we're seeing the patients. So what I do recommend, if you do have symptoms, to call ahead, either the Baptist Care on Demand app, or call your primary care's office, or call your infectious disease doctor or your pulmonologist. Call ahead so that we can give you instructions on how to safely present into the office, or how to get tested if you have that disease process. Or if you need to go, if you're a little bit sick, or you're short of breath, you're having chest pain, those type of things, then I think at that point, presenting to an emergency department for evaluation becomes more important. Those specific symptoms are very important, and they distinguish like viral illness from disease that needs medical attention acutely.
Wait, I have a question for Dr. Perez Morales that's here along these lines. Someone here wrote saying, is there any literature pointing out to reinfection in hosts previously infected with COVID-19?
Yeah, that's actually a very hot topic right now. From Asia, predominantly China and Japan and Korea, we're hearing about people that were discharged from the hospital after recovering from COVID-19 infection, having tested negative by PCR, only to get readmitted and then test positive for COVID again. And based on the data that is available, it's really hard to say whether that's a true reinfection, or what we suspect may be predominantly a false negative PCR at the time of discharge. We know in animal studies, rhesus macaques that have been given the virus, infected, they cleared the virus, and then were re-challenged with the virus, they did not become infected. Now, potential explanations for this phenomena could be either low immunity, from the virus, people that for one reason or another do not develop neutralizing antibody titers to the infection, therefore they're prone to become reinfected if re-exposed, although this is a phenomena that is not necessarily new. I mean, it's been observed with other coronavirus infection, except that typically the immunity following those infections lasts for months or even years. So the reinfection phenomena is something that is not it hasn't been well studied, and we definitely don't have any answers to that effect, but we don't think it's reinfection. No.
All right, thank you. Thank you very much.
First, Morales, can you talk to us about the people that are potentially walking around that are communicable and non-symptomatic?
That was me?
Or if any of you guys want to talk about it, asymptomatic communicable people, because one of the things that I get a lot in terms of questions about people is well, you know, if we're feeling fine, you know, can we visit our cousins that are feeling fine also, you know, and in terms of can we get together in a group, you know, I've been feeling really well for 14 days, can I go visit my grandma, you know, for instance, and as, if any of you guys want to touch base on it, I mean, there is a potential for infection without symptoms.
Yeah, I mean, asymptomatic carriers are why this disease is so contagious. We know that you're most contagious, you're most likely to pass on the virus prior to having any symptoms. In addition to that, what Dr. Perez Morales was saying was that a lot of these patients remain positive for a long time, even in the absence of symptoms. You know, the CDC was saying that you should self-quarantine, and 14 days after you don't have symptoms, you can come out and you don't need to be quarantined. But I have a nurse practitioner who is 3 weeks out from being infected with coronavirus after a trip to Chicago that she took, and her father's a PCP, and she tested herself, and she's 3 weeks out from having symptoms, and she's still positive, you know. So that's another thing, is that some people don't clear the virus as quickly as you would expect. Now, I don't know, you know, she's on the other side of that hill, of that peak. I'm sure she's on the other side of that viral load. She's 3 weeks out of symptoms, but I don't know if she's contagious or not. You know, she's testing positive on repeat swabs. Obviously, she can't come to my office.
You know, I'm sorry to, because I want to make sure I don't forget. That's another topic that has been debated quite a bit. There's a recent study from Germany, albeit very, very small, 9 patients that had viral cultures after having repeated serial positive PCR testing. The viral cultures were negative. What I'm trying to say is that we are beginning to think that PCR positivity is not necessarily synonymous with infectivity. And even though the PCR is detected, that person may not have enough viral load to be contagious and infect other people. And this is a phenomenon that even happens with tuberculosis. Sometimes after treatment, you may still have a positive PCR with no viable bacilli and negative cultures, but the PCR will be positive. So we're seeing a lot of these patients that 38, 39, 40 days into their illness is still testing positive. However, there's also a tendency to believe that these people are no longer infectious. They are a problem for, you know, from the health control point of view, because nobody knows what to do with them. But truth of the matter is they're probably not infectious.
So just for the people that are on the Zoom, so they can know what PCR is. PCR is essentially when you take the virus from blood or from some sort of sample where you can have the viral DNA, and you make millions and billions of copies of that virus so that it's then easily detectable by the machine. And so what you're doing when you're testing for this virus in the blood is you're actually taking it and replicating it millions and billions of times, so it's very easy to see. And so I guess that's why Dr. Perez Morales is saying you could have a very low load in your blood, but since the whole point of PCR is to replicate it a gazillion times, that's why it comes out elevated on these assays, on these tests sometimes.
Right, and they're only amplifying a little sequence of the virus. They're not amplifying the whole virus. For those guys out there that are nervous about what they're amplifying, just a little sequence. But yeah, if you have some broken down particles in your body, like Dr. Perez says, of that sequence, you know, weeks afterwards, but they're not infectious, you're still going to amplify those amounts, and you're still going to be positive. So I think this takes us into testing a little bit. Carlos, I don't know if I'm sure that's going to be a lot of people's question out there, is what's going to go on with this testing, and how are we going to be able to get back open with the use of testing, and where are we with testing, and how much more testing do we need, you know, and what type of testing do we need, you know, in order to be able to open up. So I have a lot of thoughts on it, but I'll let you guys go, because I know I'm good at talking. So
no, and the other thing that kind of loops into that whole thing and puts a loop on the conversation we were just having is why, you know, in terms of being able to go see your cousins, you know, why was it that New York City was so much more effective than Florida or than other places in the country? And then how, you know, looking forward, we can continue our behaviors that are positive, that have limited it. And also, you know, how testing and the scientific community and our doctors and those resources are going to make it easy to complete the task of not having another peak, since it looks like we have passed our peak here in Florida.
Can you guys talk a little bit about that, numbers? Because I'm sure these guys want to hear, you know, you guys are in the front line. What can you tell us about numbers? You mentioned peak. We hear that in the news all the time. Where are we? Anything you can shed a light on that, and then we can focus on the testing and trying to open up and so on. But I leave it to you guys.
The peak information is going to be different for everybody, you know. So going back to something that Bert said, Miami is culturally very different than New York. You know, in New York, people live much denser. They actually have a functioning public transportation system that we don't have in this, you know, in this town. So people actually use public transportation to get places.
Metro Rail, baby.
What's that?
Metro Rail, man. Come on.
Metro, yeah, Metro. Okay.
How dare you?
So yeah. So you know, so we don't have density in transportation. We don't have density in our living areas. You know, and you're starting to see that helps us make social isolation moves a lot easier. So there's different areas to our peak. I think New York is reaching their peak by basically infecting a ton of their population, and they're actually potentially going to actually reach herd immunity before there's any vaccine available to them. But with our social isolation here, we've managed to what you all heard out there, blunt the curve. And also that, unfortunately, when you blunt the curve, it does delay the peak of that curve. So the negative, I know everybody out there that's hurting for cash and hurting for employment, you know, that's the painful side of blunting that curve. The good news I can tell you is it's better to be, you know, if I had to pick between being broke and being dead, I'm gonna pick being broke. You know, so the good news is less of us are gonna die as a consequence. But yes, this blunting of the curve is gonna delay the whole process of this disease, and this curve may not be our only curve. Which is one of the things that's kind of scary out there. So we're on the other side of this initial wave of a curve, but if we let go, there is going to be an expectation that the infections are going to start coming back up again, because we're nowhere near where we need to be for herd immunity. We're at a very small percent of our population being infected. So as we let go, there will be a small peak starting again of infections and presentations to our hospitals. As long as they're within a volume that we can control, then we will have less mortality per case than some of these other places. But in order to let go, which is where we were transitioning into testing, we need to get really, really good information as to who's infected, who's been infected. If we believe what Dr. Perez Morales, and we're hoping he says is true, that once you're infected, you should be good, at least for a while, or at least till we get a vaccine. You know, so we need to know who's infected, but what we really need is tons of viral testing and very sensitive tests that can to actually test healthy people, which is weird. Until now, we've been testing people presenting with symptoms so that we know who they are. But what we need to move forward now is we need, in order to do this, we need almost 2 million tests per day in the United States of America, when we currently are at about 150,000. And we need these tests on our supply chain workers, on our hospital workers, to basically understand who is infected early, so that we can basically remove them from the population fast, so that we can gain control. What happened here in Miami is we probably had this virus around when the Super Bowl was here. We just didn't even know it. And things rode out of control from the Super Bowl forward. Mardi Gras New Orleans sunk them. I mean, that's what happened in New Orleans. Mardi Gras overwhelmed them. And spring break here was about to knock us into New York style numbers had we let it run, you know, with Ultra and everything else that was planned. So what we need to do now is a soft opening, you know, not a big opening, and massive amount of viral testing that we're not ready for yet because we don't have it available, in order to be able to keep tabs on this virus and not have another large upswing. But will there be smaller upswings? Yes. Will there be focal areas that fail the soft opening and they need to be re-quarantined? Probably. That's what it's going to look like, small areas of quarantine. But there's going to be a lot of testing of now healthy people for exactly what Michael Hernandez was talking about, those walking infectious individuals that are asymptomatic. And those are the people that if they're dealing with large populations of people, like working in a nursing home or working in a school, we need to test them in order to provide safety, to be able to get back out there.
And just as an addition to that, you know, the other testing that will be available to us will be the antibody testing. You know, I don't know if Dr. Perez Morales has already spoken about antibodies and whether you could be reinfected, but I think generally the medical community feels if you've had the virus and you have the antibodies, you are protected. And so that's having widespread testing for antibodies is going to be something that's going to let us know whether or not you've been infected with the virus and whether or not your immune system is now geared up and ready should it be confronted with the same virus again.
Well, I haven't, but I was about to. You know, Immunology 100. IgG antibody testing, or serological testing, what is commonly referred to, means old infection, recovered infection. IgM, typically acute convalescent infection. There are a lot of variables, you know, between IgG and IgM, but for practical purposes and sake of discussion, that's what IgG means and IgM means. For COVID, we have two methods of diagnosis at this point. The PCR testing, which is acute diagnosis, and the antibody testing that is rolling out, that at this point, the landscape is very variable and highly unverified. In order for us to be ready for reopening, as Dr. Hernandez was saying, we need to have a massive scale of testing available. And we're talking about testing that is FDA approved, standardized, you know, guidelines, and easy to interpret. Those tests are going to be better suited for public health surveillance and vaccine development. They should not be relied upon for diagnosis. The testing, the serologies that we have available right now are probably cumbersome when it comes to interpretation of the test. They have not been properly validated. We don't know how sustained the immunity will be. And there's basically a lot of unknowns, if you ask me. So in order for us to be ready to reopen, again, we have to have massive amount of testing. We have to have a very proactive contact tracing system, which are basically the two oldest epidemiological tools available for disease tracing. We have to have the promise of a vaccine, which is probably 12 to 18 months away. And at least we got to have a weapon to fight this disease. Right now, we don't have an FDA-approved medication to treat it. We're all doing what we can for these patients, but as Dr. Hernandez said, hydroxychloroquine and azithromycin, plus or minus, is not treatment. 50-50, you know, 2 weeks ago, if you asked me, I would say the jury out there say 50-50 for hydroxychloroquine and azithromycin. If you ask me today, I think there's enough proof to say that hydroxychloroquine is probably not effective. And as we all know, there's been a lot of cardiac-related deaths with not only hydroxychloroquine, but hydroxychloroquine and azithromycin. So that's obviously not the answer, yet it's in every protocol in this country. University of Nebraska, University of Washington, University of Michigan, University of Miami, Baptist Hospital, Jackson Health. They all have hydroxychloroquine with or without azithromycin, although most have deleted azithromycin by now. But it's basically because we have nothing else to offer these patients.
Right. Yeah, these, from a cardiovascular perspective, these medicines have a very low incidence of causing fatal arrhythmias. I think that in an inpatient setting and monitored, those risks are ameliorated. But obviously I agree with Dr. Perez Morales that, these are not focused therapies. And usually in medicine, when you have a lot of treatments for something, it means you don't have one good one. Whereas if you had one good one, that's what you'd use, I was wondering if we could also transition, now that we've talked about testing and prevention, is, one thing we've all noticed in the hospitals and in our clinics is that we're getting very few patients with other stuff coming in. There's been a lot of data in terms of where have all the heart attacks and anxieties. There's a large suspicion that many cardiovascular disorders are being undiagnosed during this time, as everyone's concentrating on COVID, A, and B, people are very concerned in going to the hospital that they're going to get COVID, and they're not going when they need to. So maybe, I don't know if some of the other docs want to talk about, the fact that the hospitals are empty of patients who don't have COVID or very severe illness. That's been what we've seen amongst our group of physicians is the consultations we're getting are almost exclusively COVID and almost nothing else.
I was super concerned last weekend when on a Saturday in the middle of the day, one of our emergency departments had 6 patients inside of it. And I was just floored with that because obviously, as you just mentioned, there are people having chest pain and there are people now having heart attacks out there, and they're not using the typical presentation, which is call 911 when you're having chest pain. Your time is muscle and you're losing muscle. Same thing with mini strokes and different things. I think folks are petrified of leaving their house and going to the place where all the virus is at, right? Where they say they think it's got to be all there at the hospital, and I'm going to go in for my heart disease and I'm going to end up with the virus. And that must be what's happening. And we're going to be paying a big price for it because all those heart attacks are going to result in lower, cardiac function, increased congestive heart failure. Those strokes are going to result in decreased function neurologically. And some of the things that we ourselves have also put aside, we've put aside everything we call elective. Nobody goes into the hospital for stuff that's truly elective. I mean, we're not in there doing plastic surgery. So really at this point, what we've put aside now for a while is some patients getting chemotherapy, some procedures that are actually important and patients may deteriorate for not having over the next few months. So if somebody's hernia now incarcerates because it wasn't taken care of as an elective procedure, it's no longer elective. So the longer we put off the usual medical care that we normally deliver in the hospital, there is going to be a big price to pay. And from the patient side, for you guys out there, if you guys have symptoms, don't fear using the healthcare system. I've been in the hospital plenty of times and I haven't gotten infected. I'm seeing the COVID patients, but we have our patients segregated. We have clean areas to manage patients that have disease processes that need to get managed. So the usual things that you present for, if you're developing an infection in your foot and you're diabetic, like was happening to one of my family members, we need to take care of that. That can't go on, because if you present later in your disease with infection, you're most likely to get septic and have many more complications. So you're absolutely right, Bert. I was floored at the lack of use of the emergency department, and I know for a fact people are out there suffering because they're not getting their usual care.
And lean heavily on your primary care physicians. Because you don't want to go to the hospital, it doesn't mean you let the daily care of chronic diseases go by. And so make sure that you feel comfortable, that you have someone that you're comfortable with, that you can contact in case of a question that you have regarding your health, and be educated about your health and seek out physicians, because we're all still working and we're all still battling against the virus, but we're all still have our previous enemies who we're also battling against. So
I have hey, thanks, Bert. I'm trying to, we have like 10 minutes left and I want to see if I get some questions in here. Some people are asking about masks which ones work, and not only that, how are you guys doing with equipment? Are we okay here with Miami? Do we have enough for the hospitals and for the first responders?
We've been good in terms of PPE or protective equipment, personal protective equipment, at least in our facilities.
I think there was, yeah, Mike, and I think the physicians, especially like the pulmonary doctors and the critical care doctors, have had access to those things. But it's also interesting that in the hospitals, the physicians who are less on the totem pole in terms of front lines of the COVID, sometimes probably have felt similar to some of the people on the streets in terms of having access to, enough masks and enough PPE to really feel safe. I'd be interested to know how Baptist has dealt with that. But I know most of the institutions, whether it's Tenet or HCA or smaller hospitals that I visited with, have had some degree of rationing or at least very serious protecting of equipment. And that's just been a matter of fact throughout the process.
We've mitigated a lot. I mean, Michael Hernandez, partner, and I, talked about giving access to our cameras to our consultants. So do we really need to all go in the room if one of us has already examined the patient? Can we share that information, avoid multiple trips into these rooms, avoid use of that personal protective equipment multiple times for the same patient? So we have, like at Baptist, we have 235 hardwired ICU and step-down beds that are able to see these patients. And we made access, gave access for Michael, his partner, for Dr. Chaparro from cardiology. So for the consultants that we are going to need in managing these patients through this crisis. And that diminished a lot of the possible communication of disease, one, to our healthcare workers, but two, the use of that personal protective equipment is able to spread. The other thing we moved to are those masks that are reusable. So you'll see a lot of our frontline staff now has those N99 masks. So if you guys think about like that movie Contagion, with the mask with the two filters on the side, that's what they're using, and they can use that for a longer period of time as opposed to the throwaway stuff that we've had. So between that, we've really done well with that. And as Michael said, we've been well within our ventilator capacity. We've been very smart about and efficient about using it. But also, we weren't New York, to be fair. We weren't, I'm not putting them down. I think they did an amazing job. We weren't tested to that level that New York was tested at, and had we received all those patients, I don't know if we would have had enough stuff. And I thank the Lord that wasn't our case.
Hey, Mike, there are masks that we use in the hospital to protect ourselves, but when people use masks out in the street, in the supermarket, primarily they're protecting others maybe. I don't know if you want to talk about that in terms of masks and how that works.
Yeah, I mean, for the most part, what I'm using when I go into a room is not what I use when I go to the supermarket per se. But if everybody wears a surgical mask, you're not so much protecting yourself, although you are in some degree protecting yourself because you can't really touch your nose, you can't really touch your mouth. So in that way, you are protecting yourself, but you're really protecting others from a sneeze or a cough. So I do think that when we reopen, I don't think that we're going to be able to get to that number of a million a day in the near future, although we are ramping up. But for the most part, when we do reopen, it's going to be it's going to be a little bit different in the sense that you're going to see everybody with a surgical mask, whether our leaders mandate it or we just do it ourselves. I will say, if you do have access to an N95, I mean, I would wear it if I was going to the supermarket. I've been to the supermarket a couple of times. I actually do my own shopping. Okay, not like Martinez, Moreno, and Perez Morales, big shots. Okay, I actually do my own.
Highly I can't stand wearing an N95 myself. I mean, if I go wear that N95, it's going to cut into your skin. In order to wear it properly, it's got to make a massive seal. They're very difficult to wear. Some of our patients, Mike, some of your patients like that have COPD, they really can't even tolerate wearing a mask like that anyway.
They go nuts. They get panic attacks.
They're very restrictive masks. And I don't use an N95, and I wouldn't, just because it's not going to really protect anybody around me from me any more than wearing a surgical mask, I think currently. But also just because it's impossible to wear them for a long period of time. Our skin breaks down in the hospital. We have to constantly make adjustments for this mask, and it digs well into our nose and our skin. I have tons of friends with breakdown on their face from wearing their personal protective equipment. So I really don't recommend the N95 for anybody on the street. I do recommend that if you all wear a surgical mask to diminish the aerosolization of your own stuff that goes out there. And I would probably ask other people to wear it too. If you're out there, I wouldn't feel comfortable in a store with a bunch of people breathing on top of me. At that point, you can't control it, but if you can try to maintain that 6-foot distance everywhere you go, I think you'll be safer for doing it. That, again, the social isolation really worked with this disease. It's amazing how it worked. I didn't know if it was going to work that well. I was petrified that we were going to look just like Italy, and it worked. It was amazing. It really cut down the amount of virus on the street really quickly. So if you guys do open up, still practicing that or being conscious about it. And the other thing that I loved coming out of New York that one of the guys said, I forgot the video, but if you touch something, Purell it, keep your hands clean. Whenever you touch stuff in public, keep your hands clean. Because like Michael said, the mask might not really protect you from you, but if it keeps you from putting your hands to your face or your hands in your mouth or rubbing your nose by mistake right after you touch the doorknob that the guy right before you touched, it will make a difference. And keep your space is clean. That's the other one. When you're home, keep your area and your environment clean so that you can let your guard down, because you're going to touch your face at home. But keep your area clean. Keep the outside fomites, from coming into your space. But I don't think you need an N95. It's not recommended. And it's a little bit overkill. And some of you are going to feel really uncomfortable and misuse it anyway.
Yeah, neither do I. I think you need to go back to the basics of transmission. This is not an airborne virus, and I want to be careful with that. There's a paper in the New England Journal of Medicine suggested that this was airborne transmitted, but that was an experimental 3-jet nebulizer that developed conditions that are not the ones we see when you cough, when you talk, and when you sneeze. Therefore, the aerosolized particles generated in that experiment travel significantly, longer than, droplet nuclei with microbes would in a natural setting. So looking at it from that perspective, that this is a droplet transmitted person-to-person disease, a surgical mask should be more than effective for the purposes that we're talking about. Being out in the community, going to the supermarket, being in public, and keep your distance. Social distances, I think it's important, it's paramount. It's been proven that these droplets do not travel longer than 6 feet. They immediately drop to the ground. They're heavy. So from that perspective, it should be okay to use a surgical mask. There's absolutely no need for an N95 respirator to go out in public or to the supermarket. Sure. I agree with that 100%.
Thank you, Doctor. Actually, I have one more question for you, and we're going to wrap it up. Someone here is asking about the seasonality of the virus and what might our next winter and flu season look like. Any comments on that?
Yeah, we don't know the seasonality of the virus. We have all said and expected that because the virus is sensitive to heat and ultraviolet light, the summer would bring down the numbers considerably. But when the pandemic started, there was actually summer in the southern hemisphere, and there was still COVID-19 transmission. The fear with the seasonality is that there's somewhat of a concern that during flu season, we may have circulating coronavirus as well. And that could be a resurgence and a second wave of cases. If that's truly the case, we're in for really a major problem. Because chances are, based on my estimates, even though the statistics are improving, the number of admissions are improving, the number of cases are steadily going down, I don't think we're going to be ready come September, October, flu season, flu vaccines, if we have another wave of coronavirus circulated in the community.
So getting that flu vaccine is super important. I mean, would you say, Dr. Perez Morales?
Absolutely. Absolutely.
Okay. Well, good advice. And on that note, we have to end. I wanna thank you, the panel. I want to thank all of you for taking the time and being part of this. There's a few people I need to thank before we just let you all go. Dr. Orlando Puente, thank you for helping us and putting this panel together. Jose Pep Lopez Varela, like I said, was my wingman in the beginning, behind the scenes, helping me out with that. Board members, Tony Castro, Cres Ruiz, Javier Marical, Raymond Branger, for being part of the process, and the future ones as well. Advancement team, Teresa Martinez, Phil Hernandez, thank you so much. And I want you to be on the lookout. Next week, we will have another AVE webinar with the lawyers. We will have Fernando Arang from 75, Sergio Mendez from 77, Javier Perez Abreu from 78, Jordi Gusso, 83, and Javier Basnuevo from 05. Very interesting group there. Let's see what happens with those guys. But be on the lookout for that invitation. I'm going to plug Be Connected. Those of you that are alumni that are not on Be Connected, please sign up. This is a great way to connect with these doctors and continue asking questions. We will be sending out a video. You will have access to this. You will have access to them. We'll talk. We'll do a little post, and I'll ask them to see if we can continue asking questions. There was a few questions here we couldn't get to. And we're going to have a little survey at the end there, if you guys don't mind answering for us. Pep, you ready with the survey? Pep Lopez Varela is going to do something for us. So if you guys get the chance of doing this survey for us, it's very simple. Just bring your phone up there and give us an idea as to how we did and what you would like to see in the future. And we'll leave it up there for about a minute. But listen, again, Bert Moreno, Eduardo Martinez DeBouchet, Mike Hernandez, Juan Perez Morales, thank you all. You guys were amazing, incredible, and I appreciate this, and proud to be alums, and a father of an alum right there, buddy. Thank you, Perez Morales. You guys are great.
All right. Thank you. Be safe.
Right. Yeah.
Take care, guys.
See ya.
Bye, guys.